Hi everyone. Well, we are ending our second day at the annual scientific meeting for the Canadian Rheumatology Association and Arthritis Health Profession Association. We're in Quebec City, and my name is Isabelle Troïtzky. I'm with the Arthritis Consumer Experts and the Global RA Network. And tonight, I'm thrilled to be joined by Dr. Charis Meng. Thank you for being here with us tonight. Dr. Meng is rheumatologist at the Inflammatory Arthritis Center of Excellence at the Hospital for Special Surgery in New York City. So, welcome to Quebec. Not too cold. This is nice time. So I'd like to start by asking you, what. So you're a rheumatologist, but what are your areas of interest? Any research areas that you're focused on? Anything about your involvement in rheumatology?
Sure. I'm a rheumatologist with clinical expertise mostly in inflammatory arthritis, which means rheumatoid arthritis and psoriatic arthritis.
Okay.
And my areas of interest in research are also looking at rheumatoid arthritis and trying to find the differences that cause pain in rheumatoid arthritis, both related to rheumatoid arthritis and other reasons outside of rheumatoid arthritis.
All right. So I know that you're actually presenting a poster tomorrow.
Right.
Can you tell us a bit more about what this is and what patients may take away from that poster?
Certainly. We are looking at an early arthritis group of patients in CATCH, which is a Canadian registry of early arthritis patients. And what we were focused on were patients who had more tender than swollen joints, which we found to be very common when patients first are diagnosed with rheumatoid arthritis. But even after a year of treatment, having more tender than swollen joints actually persists in about a third of patients. And what was of interest is that some studies have looked at having more tender than swollen joints as potentially having reasons outside of rheumatoid arthritis as the cause of that pain, which is very important to know, because if it's not all the rheumatoid arthritis, then the treatment would be different. We would treat rheumatoid arthritis with specific medications. If the pain was from osteoarthritis or muscle spasm, we might do physical therapy or a different medication. So that difference is very important for both the rheumatologist and the patient to know about. So that's why we're looking at this group of patients with more tender than swollen joints. And the second thing we wanted to look at was how does this affect the patient's quality of life? What do the patients report? We call this patient-reported outcomes. And what we found was that patients with more tender than swollen joints actually had a lot more problems with staying at work, having poor function overall, worse sleep, more fatigue. So many of the patient-reported outcomes were worse in this group of patients with more tender and swollen joints. So it's something that is very important for us to know more about and learn what is exactly going on in these patients that's causing such an impact on their function and quality of life.
Yeah, and definitely RA is one of the key factors for people not being able to function at work and not being at work.
That's right.
Not active.
That's right.
So yeah, very important. Well, I'm eager to see that tomorrow, and we may be able to share it, in the next few weeks maybe over the ABN or somewhere else. you're having patients visit every day. So I'd like to ask you, what's your approach, or what approach do you recommend with patients? Because we advocate for patients to be heard and to take part in their treatment, in managing their pain. So what's your approach towards patients and their involvement in the treatment?
Sure. The first time I meet a patient, I think it's really important for me to understand how their symptoms started, and how the symptoms evolved, and how they impact their daily lives. So it helps for me to just allow them to tell their story in an open-ended kind of way. And then as the story progresses, I may ask questions to help elicit specific things that I think will be important to help us together come up with a good therapy plan. And that includes, of course, their other medical history, what other medications that they may be taking, and their other activities, their employment, and so forth. I think establishing that trust from the beginning is very helpful, because rheumatoid arthritis really is a journey, and knowing that we're partners in deciding on both the treatment plan, how they respond, how we may handle potential side effects, different phases of life. It's very different when a young patient who starts therapy then may want to start having a family. How is that going to affect their medications? That's something we would want to discuss ahead of time. So it's really a journey over time, and if that trust is there, it just establishes a foundation, I think, for more success down the road.
Yeah, true. And one of the topics of this year's meeting here in Quebec is Reconnect, Renew and Reimagine.
That's right.
So the Reconnect is very important after 3 years of pandemic, and definitely connecting with the patient, but also connecting with the whole team around the patient.
Right.
And the healthcare system. So how do you see that interaction and connection with the whole system around the disease and the patient?
You mean since the pandemic?
Yeah.
Or yes, I think the pandemic really created a lot of challenges for us, kind of getting back into the routine of regular follow-up. Our sense of time, I think, got distorted.
Totally, yeah.
I've seen my patients come back, which is very important, because we are prescribing medications that require us to monitor, make sure they're okay, make sure their labs are okay, so it's something that's starting to improve, but I'm really grateful when my patients are making that effort to reestablish care, or kind of get back into the habit of a more routine follow-up, which the gap, started to lengthen during the pandemic out of necessity, but now it's a good time to reestablish regular follow-up.
So did you find they were needing that those visits, those physical visits? And
Yes. For the most part, I have to say, most of the patients were fine. There was nothing, major happening. But yes, rheumatoid arthritis, it can fluctuate. Yep. It can change over time, even when we haven't made any changes to treatment. Yep. It can still fluctuate. So I have found that with some patients, it was important, some of the developments that they told me, and actually did cause us to make a change in their therapy. And so I was just so glad that they came back.
So we've seen also during the pandemic virtual care, picking up, so I know you practice in New York City, but the U.S. is a huge country, Canada as well.
Right.
We have a lot of inequalities, across the country, and the coverage with physicians and the specialists is not always it's not equal everywhere.
Right.
So virtual care has taken a big place in the life of patients.
Right.
How do you feel about that? Do you continue to do some virtual care? What's the place of virtual care now that the pandemic is kind of slowing down?
Right. No, that's an excellent question. I think the virtual care really saved a lot of our rheumatology care when we didn't have other options, and at least it gave me FaceTime with the patient, and it reassured me that they were doing okay, that they were not getting more infections during the pandemic. On the medications. I think now it still has value. I think for a new patient, I would prefer to see them in person because, even with the study I was mentioning, tender and swollen joints, you need a physical exam.
Yeah.
It really does make a difference. So for the introduction, a baseline, it's good to, certainly see them in person. For follow-ups, it can be, I think if they're doing well, there's no major issues. It's also, I think, fine. But optimally, I think it's good for us to examine our patients. Sometimes patients might get used to certain symptoms. They naturally can accommodate if their RA may be flaring, and they may not tell me about, all the ways that their RA may be affecting them. But if I see something, which may be difficult on the screen, you can do a limited exam virtually. And there probably are opportunities to teach patients how to examine their own joints, which that's actually been studied, and there has been some success there. But I think we need more training, and we need to formalize that a little bit before we strictly rely on that.
Yes, no, exactly. So, before we wrap up with some key messages and key insights, any questions out there?
In terms of virtual care versus in-person care, would you say you're spending around the same time with the patient?
Yes, I think so. If anything, because the exam is shorter now, probably there's more time spent talking. Also, because I don't have the exam to rely on, I really need to rely on their story and what they're telling me. So the length of the appointment, I find, is the same.
Because in our surveys, we have found that many patients are finding that it helps to eradicate the barriers to access to care, because some people may not be able to get to a clinic, or their closest clinic is an hour or 2 hours away. But at the same time, we know that when patients go into the clinic, they feel that they're rushed.
I see.
A lot of them have commented that they feel that they're rushed. So do you have any recommendations or tips for patients who feel that they're being rushed out of their clinician's office?
Yeah, that's curious. That might have to do more with how perhaps the virtual visits and the in-person visits are being scheduled. But at our practice at Hospital for Special Surgery, it's the same amount of time, whether it's in-person or virtual. Perhaps you don't, I suppose for an in-person visit, there is the time for the nurses to do their intake, and to perhaps have them change into a gown, and that does take time. So that probably is contributing to the shorter visit in person. But I would also offer that I think the nurses also provide good contribution when they do their intake. It's they might go do a more thorough intake of their medications, and of course we get to have their vitals done, which is also useful. So it's a different kind of visit, and I think it's okay to have the virtual visit as long as it's interspersed with an inpatient visit.
So to wrap up, is there anything you'd like to say to our viewers and patients out there, RA patients specifically, about the way they're coping with their disease, with their pathway to treatment?
Well, we've all been through a difficult few years together. I hope you are all encouraged that all the rheumatologists in Canada have reconvened this year for this meeting, and if you haven't had a chance yet to reestablish care with your rheumatologist, I hope you do so soon. We truly look at this as a partnership, and if you're listening to this, that already is a great sign. So thank you for listening.
Oh, well, thank you very much. Dr. Meng. Thank you all. And I think that concludes our second day here at this meeting. So be well, have a nice evening, and hopefully we'll see you on this channel tomorrow. #CR Arthritis. Thank you. Bye.
Thank you.